Hello, everyone, and welcome back. I'm Joe Chappelle, and you're listening to episode 53 of the OBGYN podcast. As always, thank you all for coming back week after week. You know, I've heard from many of you that you really enjoy the topical episodes like the monthly checkups and the journal clubs like we're going to do today, but that you also love the deep dives to topics that we do from time to time. And if you feel that way, then I have good news for you, because we have a slew of great content lined up for the next couple months, including diabetes in pregnancy, atopic pregnancy, microbiome in pregnancy, risks and benefits of cesarean delivery, and there's more after that. In addition to that, Jerry Ballas and myself will be at the National Perinatal Association annual conference in Providence, Rhode Island from April 3rd to April 5th. We'll be doing some interviews and then a special episode related to that topic of the conference, which is confronting disparities in maternal-infant health. I'm really excited about it. Jerry's really excited about it. And I think you're really going to enjoy what we put together. Also, if you either live in the area or you're going to be there, then get in contact with myself, and you can do that at feedback@obgyn.fm. Let me know, and maybe we can meet up and we can talk about OBGYN in the podcast. With all that being said, today is the Journal Club for March 2019, and to help me get through this paper today, I have a very special guest, and that's Dr. Julie Lian. Welcome.
I'm very happy to be back.
So, Julie, I'm very glad Julie's here today because we're talking about one of the things that I know that she's passionate about. The paper that we are using, or we're going to talk about today, is opioid use after laparoscopic hysterectomy, prescriptions, patient use, and a predictive calculator. And that was written by Marin Wang et al. And published in AJOG in March 2019. Now, the reason I say Julie's a perfect person is because she has worked extensively, both in her fellowship and as an attending, on ERAS. And I don't know, before we get into the thing, do you want to talk a little bit about ERAS and what you've been doing at our hospital and with your patients?
Sure. So ERAS stands for Enhanced Recovery After Surgery, and it's basically a bundle where you put together preoperative, intraoperative, postoperative components to a patient's care for surgery to maximize their outcomes. So things, for instance, like minimizing the MPO status, patient preoperative education, intraop multimodal analgesia to minimize opioid use, and then afterwards also stressing postoperative multimodal analgesia as well. So during my fellowship, we were doing at Stony Brook, at least in the benign minimally invasive gynecology department, we were utilizing different components of the ERAS protocol, but never really sort of put it to paper and made it more official. So during my fellowship, I worked with the anesthesia department and made a more formal protocol, and specifically during the pre-op and intra-op process, emphasized multimodal analgesia to decrease the opioid use. And
that's been working well for you guys?
So far, we're still we're doing a QI study, and we're still collecting data for it. But some of the data that we've seen so far is pretty much very similar to this paper that we're discussing today, in such that we found that we were definitely overprescribing patients opioids after surgery.
Yeah. So I think, this paper tackles one part of it, which is how much opioids do we prescribe, and can we predict how much people are going to use, and that's valuable. And actually, I did a similar study that's not published yet on the OB side with one of our residents last year. We couldn't really get a predictive calculator to work with our data. Maybe it's just a little more complicated with the different things that can happen during delivery. But I think the same approach probably will work on the OB side. So that's one part of it, and I think the other part of it that you're working on seems to be not only can we predict what people are going to use, but what can we do to decrease that? Like what tactics do we have that can do that? So all of it kind of goes together. And again, in the introduction in this paper, they really talk about what we think we all know, and we've talked about on this show a few times, is the opioid crisis that we have in the U.S. and how a lot of it is due to us. Overprescribing medication, and then they're left hanging around, and then they address that in this paper, and then someone else uses those opioids or starts abusing them, and so all of those extra pills just add to the problem that we have.
Right.
All right, so why don't we jump into the paper then? The introduction isn't very exciting. It's well written. I'm not saying it's not good, but it's stuff we've already heard before, and I think most of us know, so I'm not going to go too far into it. At the end of it, they do talk about what their primary and secondary outcomes, and as you all know, that's where I like to hone in. So their primary outcome was to describe opioid prescribing practices and to measure post-op opioid use after minimally invasive hysterectomy. Their secondary outcome, which is really, I think, the meat of this paper is to identify preoperative factors that could predict high or low postoperative opioid use. Now, if I have one criticism about this paper, is that I think their primary outcome has already been done.
I agree.
And they actually, they cite those papers, so it's not that they don't know they exist. So I actually think that their outcome for this study should have been their secondary outcome, because that's what's novel here. And all of their stuff in the beginning, all those primary outcomes are just feeding into their secondary outcome anyway. So I don't know. I think that they were too conservative on their primary outcome here.
Right. I mean, maybe this is a initial study idea, and as they do discuss in their discussion, that their next step is to validate this this calculator. So
yeah, fair enough. It's a small criticism. At the end of the day, all the data is there, so it doesn't really matter. So for their study, they did a prospective survey-based study at 2 community teaching hospitals outside of Boston. One is in Newton and one is in Burlington, Mass. Those are both suburbs of Boston. They did it between March 2017 and April 1st, 2017 is when they started, and they all finished in January 2018. They had, I believe, 5 surgeons who were the primary surgeons for this study, and I think that is going to be important. They collected demographic information, medical and surgical history, preoperative pain medication use, which is important for people who are already using opioids. One thing I thought was interesting here, and I had never seen before, is they asked women what their expected pain after surgery was, and I thought that was really interesting. Is that something you've seen before in the literature?
No, I haven't really seen that. I mean, I definitely have seen sort of existing pain, but not sort of what the patients expect their pain score to be after surgery. So that was interesting. Yeah,
and I think we have seen in the past, in many things, that patient expectation really plays into their experience of whatever it is. There's a famous story, which may actually, who knows, not even be true, of an oncologist in Boston, actually, a GYN oncologist, who all of his hysterectomies, laparotomies, that is, went home post-op day 1. And where most places post-op day 2, or maybe some even 3, is kind of standard. People are like, well, how did you do that? And he said, well, I just tell everybody from the first visit that they're going home on post-op day 1, and then they all go home on post-op day 1.
Right.
Right. And so expectation is interesting. So I think that was an interesting part to me, is what effect does the expectation of pain have on their perception of pain afterwards? I'm not sure they answer that in here, but it's something I never thought of before.
Mm-hmm. I mean, definitely patient counseling preoperatively and setting goals and expectations is definitely important. So I think that might be something I would ask the patient during the pre-surgical visit. How badly do you expect your pain to be after surgery, and sort of talking to them more about that, and sort of either calming them down about their expected level of pain, or explaining that it's normal to have pain after surgery.
Right.
Which is what I often tell patients, that our goal is to not make your pain 0 to make it, but it's to make it tolerable.
Right. And I think, and we'll get into the results, most people had a reasonable expectation of pain, but there's a wide variety. And you do have the people who say, oh, I'm going to be in 10 out of 10 pain. You tell them, okay, no, that's not what it's going to be like. And you have people who say they're going to, I'll be in 1 or 2 out of 10 pain. Okay, well, that's not true either. You are having major surgery, and it is going to hurt, right? So it's about moving people back to the middle.
Mm-hmm, right.
So then they also completed, I believe, 4 surveys. One was about drug abuse, one was about depression, anxiety, and then another one about pain, catastrophizing. I can't even say the word.
Catastrophizing.
Thank you. And that is something I'd never seen before either. I'm sure it's something they use in like the psychiatry literature, but I'd never seen it used in here. Are you familiar with that one?
I think they use it more in anesthesia and pain, the pain literature, but I've not really seen it in sort of our OBGYN research, but definitely have seen them in those other areas.
Right. So all of those things, and depression and anxiety, we definitely know have an effect on people's perception of pain. So that's very important. And I think we have been learning even more over the last decade how much depression and anxiety can play into all of these other aspects of medical care that you may not assume are related. I kind of actually assume now that everything is related to depression and anxiety because it seems to have an effect on everything. So like I said, they had 5 surgeons. They were all told not to change their opioid prescribing practices while in the trial, which makes sense. They collected intra-op, information, including complications. Complications were defined as any injury to other organs, conversion to laparotomy, or intraoperative transfusion. It was interesting to me that they did not include postoperative transfusion. I feel like maybe any transfusion should have been used. I'm not sure it would have changed the data very much, but I just thought that was an interesting choice. Then they surveyed women at 1 week and 2 weeks. They also called them at 4 days and 7 days. Again, I don't think that's so important. I just want to say that that's a lot of work. And so I'm impressed about the amount of effort that was put into this. That's a lot of phone calls.
Right. I mean, for our QI project, we were also calling patients post-op day 1 to 2 and then 1 week out. And then we actually did a survey when the patients came in for their 3-week post-op follow-up. So we utilized the help of the residents and the fellows extensively.
All right, the free labor.
Yes.
Like I said, we already talked about the primary and secondary outcomes. So we'll get into the results. So during that time, there were 138 women who were eligible, and those women had to be benign hysterectomies, not having cancer or having concurrent surgery or having a planned laparotomy. And like I said, as part of the inclusion, they did also include women who did have a history of preoperative opioid use, which is important. We could talk about that a little bit at the end, I think. So out of 138 women, there were 125 who completed the study. The demographics are interesting. I think a lot of what you and I should talk about towards the end of this discussion is, does this patient population reflect our patient population? Because I think that is I don't want to say criticism, but the only part of this study that may not be applicable to other places.
Right.
So their average age was 46.5, which seems about a reasonable age.
Yeah.
84% of them are white. And only basically 5% were Hispanic, 5% were Asian, only 3% were black, and then 1% were multiracial. And the average BMI was 28.9.
Very low.
Very low, right? So from at least our patient population here, we have a much more mixed demographics. We have more Hispanic, we have more black, we probably have less Asian, actually. And our BMI is definitely a little higher than that.
I'll definitely say probably average is upward of 30.
Yeah. Right. Again, and does a 1 point or a 2 point difference matter? I don't know, but it's certainly a little different. And then in education, again, we kind of see the same thing. Almost 40% had a bachelor's degree, 32 were graduate or professional degree. I used to live in Boston, and I can tell you that these two places with hospitals are relatively wealthy suburbs of Boston, and so I'm not really surprised by this. But when you're living in a place that is not that, where 50-60% of your patients have a bachelor's degree or higher, it may skew what their expectation of pain is, how they interpret that, how they deal with that. Because pain really is more than just a medical process; it is a psychosocial process.
Right.
So that's just something to keep in mind with their study. 65% were married, 20% divorced, 10% single. Again, you're going to find much different numbers. I'm not sure it's very impactful on the study, but you're going to find different numbers, different populations. 8% were smokers, which seems a little bit low. I mean, smoking is definitely lower than it used to be, but I would say probably for our older gynecology patients that we have, it's probably higher than 8% who are smokers. I don't know what your experience is.
I would say my patient population pretty similar. I don't find a lot of them smoke.
Okay. Then 8% were using opioids prior to their surgery, which is not that high. It's probably about right. Especially given what their indications were, which we'll get to in a second. Past medical history. So 30% had anxiety. 24.8% had migraines. 22.4% had chronic pelvic pain, 21% endometriosis, 15% depression, 10% arthritis, 8% chronic back pain, and 5.6% had fibromyalgia. Now, at least in our population, again, we work with a mixed population, so we definitely have this kind of wealthier, higher educated, group of patients, but we also have the, middle to lower socioeconomic class that we also take care of. And I find that the, say, higher socioeconomic class women tend to have more diagnoses of anxiety and migraines and depression, but that the lower socioeconomic have the same prevalence. It's just not diagnosed.
Right.
You talk to them and you see all the hallmark signs of it. They just don't have that diagnosis. So I'm not sure if that would affect this at all.
I mean, I think that the people who are in higher socioeconomic classes, they have access to care.
Correct.
So maybe their depression and anxiety are better controlled than the people who are uninsured or on Medicaid. So I think that could definitely impact their recovery.
Agreed. I thought the chronic pelvic pain and endometriosis, again, that's going to really depend on what kind of referral center you are. If you are just private practice doing surgery, for your patients, I think you're probably going to have a lower rate of chronic pelvic pain and endometriosis. Whereas if you're someone like Dr. Lian or Dr. Blaber, who are getting referrals, you're going to get a higher percentage, maybe closer to this 20%. Seemed a little high to me, at least from what I do. I would say that not 20% of my patients have chronic pelvic pain or endometriosis who I'm doing hysts on. What do you think?
I would say that, I would agree. Although that population in my practice is growing, given that we've opened a pelvic pain clinic. But I don't think in my practice it's 20%.
Okay. And again, we don't know who these surgeons are, and they may have been there for a while and have a good referral base in the area, so that may be why they have that population. But again, having that pre-existing chronic pelvic pain or endometriosis could affect their pain scores later. So
definitely
keep in mind.
Yeah, I find that on the patients I do operate on who have chronic pelvic pain or endometriosis, it has definitely been more challenging to manage their pain post-operatively compared to those who don't.
Yeah, absolutely. I've seen the same. Their past surgical history was a little interesting to me. They had 40% had prior laparoscopic surgery and 43% had prior open surgery. And that just seems like a lot.
I mean, I would think the most common one would be C-section.
Okay, fair enough. I actually it didn't even occur to me that would be included in there, which is kind of silly. But you're right. Okay, I guess including C-section, that would make more sense.
Yeah, that's my thought that, the most common sort of open surgery that women of their age get would be a cesarean section.
Yeah, that makes a lot more sense. All right, so then into their indications of hysterectomy. And again, this is all just kind of describing who these patients are at baseline, because that's going to affect their post-operative pain use. The 66% had surgery for abnormal uterine bleeding. I guess they could have multiple diagnoses here, because the numbers don't really add up. 58.4% for fibroids. 36.8% had pelvic pain or endometriosis, which is congruent with the other data we saw. 12% adenomyosis, and then just a smattering of other diagnoses. 97.6% had total laparoscopic hysterectomy, and 2.4% had laparoscopic supracervical hysterectomy. Now, I'm going to ask you this one, because I don't know if there's data out there, but if there is, you'll probably know about it. Is there a difference in pain from a TLH versus supracervical hysterectomy? Has anyone looked at that?
I haven't come across any studies looking into that. Just from a surgical standpoint, I would say no. I wouldn't think there would be a difference in pain scores, but I haven't come across any studies about that. Okay.
I don't know. I mean, you are dissecting more. You are opening the vagina, which you're not doing, with a supracervical. But we ran into this. I want to save this in a few minutes, but is looking at doing local before you do your trocars. And we haven't published this data at Stony Brook, but we didn't find that there was really any difference in postoperative pain by either pre-injecting or not.
Right.
And that's probably
certainly not by 1 or 2 weeks make a difference.
Right. And that's probably because there's a whole lot of other things that cause pain other than your trocar sites. It's probably the least of your pain.
Right.
And so maybe it doesn't matter. But I know at Stony Brook, our rate of TLH is certainly much lower than 97.6. We do a lot more supracervicals. Partly I know that yourself and I do some now too is single site, and those are much harder to do a total single site. It's easier to do supracervical.
Right.
So,
right.
Additional surgeries, 76% had bilateral salpingectomies, 16% had BSOs. So that's, about 90 some percent had their tubes out, which reflects, I think, current standards. Most people are taking the tubes out at hysterectomy. And then another 4% had uterolateral, so we assume they had an ectopic or something before and only had one tube. 24% had lice of adhesions, 9.6 or almost 10% had resection of endometriosis, another 1% had ablation or fulgration of endometriosis, and that goes along with their chronic pelvic pain endometriosis, so that's probably fine. And then interesting to me, only 42.4% of them had cystoscopy. There's been a lot of talk about this really over the last 5 years, and it's funny when you train and work in one place, one institution, you basically live in a bubble. And so, I don't know, probably for like maybe eight years or more, almost everyone who does hysterectomies here does a cystoscopy after every case. It has just become kind of what the standard is. And so I read a paper, actually I think it was an AJOG, or it was a Green Journal this month, again saying, hey, we need to all be doing this cystoscopy after every hysterectomy. And to me, I thought that's a solved problem. We all do that.
Mm-hmm. Right.
But apparently not, because only 42% of this population do cystoscopy. And
they do mostly total hysterectomies as well. So that was, for me, very interesting.
Right, because you're going to have a higher rate of ureteral injury there.
Mm-hmm.
Right? So,
right.
Yeah, interesting. Then I swear we're almost done with the data here. We're getting into actually talking about the paper. But number of trocars, so 99.2% used 4 trocars, so that's an UMBI, and then 3 additional ports for the hysterectomy. So a 3-port hyst, essentially, a 3-operative port, and then 1% used 5 ports. I tend to use 5 ports when I do a multi-stick hysterectomy, mostly because I'm working with residents, and I want them to learn how to use 2 hands at the same time. If you are not working with residents, you're working with a PA or something, that's much less of a necessity. What do you do for multi-port? Are you using 2 on each side or 1 on one side?
Generally, it depends. If it's a larger, bulky uterus, I tend to put 2 on both sides, and otherwise I do 2 on one side and 1 on the other side. Although more recently, I've been trying a new configuration where I put the gel port in the umbilicus and then 1 on each side. So then technically I can put multiple instruments through the umbilicus.
Okay.
I mean, it's only one less trocar, but...
Well, the path to be getting better at surgery is to try new things, as long as they're not going to injure the patient. And
right.
Sometimes they work out, and you do a few, and you say, "This is fantastic. I'll never do it a different way." And other times you do a few, and you say, "That's not really getting me any benefit." Right? So,
right.
But you don't know until you try. Okay, and then 64% of them did do local anesthesia with trocar placement, which we just talked about. For morcellation, 44.8% of them were morcellated, and that kind of gives you a sense of the uterine size. Of course, they're also doing totals, and so they can get them through the vagina. When they were morcellating them, 38.4% were being morcellated through the vagina, 5.6% suprapubic, so I guess they're making like a mini lap, suprapubic to do that, and then 1% umbilical. Again, this is interesting to me because at Stony Brook, almost 100% of our uteruses are morcellated through the umbilicus.
Umbilicus, yeah.
And so it's interesting that places do different things, and it's all about, especially I feel like in laparoscopic surgery, there's usually one person who, over the course of a decade or so, has influenced how things get done. Mm-hmm. And then they train other people, and then they all kind of do it that way. So, we had Jim Drosch and then John Wagner, who was also trained by Jim Drosch. But those 2 guys have probably affected the way that we all operate.
Right. And that's why we all operate similarly.
Correct. So anyway, I thought that was interesting. And here, they obviously all operate very similarly, too. So they probably have 1 or 2 of those kind of people who have affected everything. So, interesting. Length of procedure, 94.3 minutes, with a very large range there, up to 344 minutes, which is long, but I've definitely done cases that long. Mm-hmm. Estimated blood loss was 48.4, which is pretty low, which is normal. Uterine weight, 321, with a standard deviation of 305. So, most of them are probably in that, 200 to 400, 500 range, which is pretty decent. And then pathology findings, so I'm not going to go through it all. Basically, 16% had endometriosis, 31.2% had adenomyosis, and that is something I want to talk about for 1 second, because this is what I found in my own practice. So preoperatively, only 12% of them had a diagnosis of adenomyosis as an indication for surgery, but postoperatively, 31%, almost more than double, actually had adenomyosis on pathology. And I feel like that's the one thing that we underdiagnose is adenomyosis. And that can be a significant cause of pain and abnormal bleeding in women. Mm-hmm. And I just don't think that we recognize it enough. And I know you also do ultrasound, GYN ultrasound, and so you also are looking for that. And I don't know, do you have any thoughts about adenomyosis? I mean, certainly it's a diagnosis where, similar to endometriosis, you can suspect, but you really can't diagnose until you're in the OR with pathology. So certainly on ultrasound, I always ask what the indication for the ultrasound is, engaging from the patient's reply. If she has dysmenorrhea and heavy bleeding, then of course I'll look for signs of adenomyosis on the uterus. But certainly it can be hard to detect, or harder to detect on ultrasound. Fair enough. I think we don't have good data on this because it is hard to diagnose preoperatively or without doing surgery, like endometriosis. Actually, even worse than endometriosis, because you can only diagnose it by looking at the pathology specimen of the uterus once it's out. But my gestalt with dealing with these women is that women with adenomyosis don't respond as well to a lot of our medical therapies as women who don't have adenomyosis, who maybe have abnormal bleeding from fibroids or have dysmenorrhea from other reasons. And I find that more of these women are the ones who end up failing all these multiple medical managements and ending up with a hysterectomy, 2 or 3 years later. I don't have any proof of that. It's just my anecdotal. Anyway, that was not related to this paper, but something that's been thinking about a lot recently. All right, so let's get into the actual the meat of this paper after I just talked for the last 20 minutes about their outcomes. So postoperative pain management. So 98.4% were given an opioid prescription. Most of them got 20 tabs of 5 milligrams of oxy. The median use was 5 tabs. 20% used no opioids at all. 52% used 5 or less, and 81% used 15 or less. And only 9 of the 125 called for refills. 16, patients, so 13% of them were admitted after the surgery, which seems a little bit high, but not crazy. Not surprisingly, because the median use was 5 and people got 20. 90% had leftover meds, and 73.4% of them said that they kept them in an unlocked location. And so those are the ones that are likely to disappear at some point if they're left. And I forget the exact number. It's in here somewhere. About 40% of them said that they plan to keep their leftover pills in case they needed them at some point. Mm-hmm. Right. So those are the ones I worry about. So as far as post-op pain, the highest pain score that was reported, the median was 6.5 with a standard deviation of 2.5. At 1 week, it was 1.9 with a standard deviation of 1.9. And at 2 weeks, it was 0. The satisfaction at 1 and 2 weeks was 9.1 out of 10, plus or minus 1.9. So that definitely goes along with the study you were talking about, where you were looking at, maybe we talked about before we started recording, that you were looking at 1 week and not 2 weeks, because by 2 weeks most people had no pain. Right. Well, I think that you justified in choosing that because at 2 weeks they showed no pain. Right. And the CDC also recommends in their opioid prescription recommendations that you only prescribe enough opioids to last a week. So they really shouldn't have pain at 2 weeks or needing opioids. And then looking at their expected pain, most people, the median was 5.75 with a range of 5 to 7. The mean was 5.7, the standard deviation of 2.2. And so if you look at the highest pain, which was 6.5, and they're expected of 5.7, that's not that bad. Although people had more pain than they expected, but it was still pretty close. So I thought that people actually had a decent expectation. Now, whether that's because they knew other people who had surgery or because their providers were counseling them well, in any case, they kind of knew what they were getting into, which was good. So before I get into the last part, which is this predictive calculator, Dr. Lian, do you have any thoughts on all of their preoperative, their post-op pain, anything there that stuck out to you?
I was surprised that a quarter of their patients used no opioids. I would say in my experience doing our surveys, I would say the majority of our patients used definitely use their medications. I would say majority of them use less than 10 tabs, but I was actually pleasantly surprised that a quarter of them did not use anything didn't use any opioids. So that was, I would think to attribute that to good counseling by the physicians.
Yeah, I mean, they don't tell us. I don't believe I didn't see what they recommend for ibuprofen and acetaminophen use afterwards. So maybe all these people are doing around the clock.
Yeah, I mean, I think they had like a very short sentence that they do recommend that they take around the clock, pretty much, Motrin and Tylenol.
Okay, so I mean, we did a study at Stony Brook, which we presented somewhere. I think it was at AJOG or last year. That we definitely saw the same difference on our OB side, that doing around the clock ibuprofen and acetaminophen dramatically decreased people's opioid use, and so maybe it's just attributable to that.
No, I definitely am a firm believer in around the clock Motrin and Tylenol after surgery.
All right. So then getting into their what I think was actually the most interesting part of their paper, and what I want to follow up on, is they started looking at predictive factors. What they found is that people who were younger, who had chronic pelvic pain, anxiety, depression, previously used opioids, had higher pre-op pain, and had higher expected pain. All of those were predictive factors of using more. None of that is too surprising to me. But it's nice, just because we assume and something makes sense, it's still nice to see that is true. The data supports that.
I was surprised that prior abdominal surgery wasn't associated.
Why is that? Why would you think it would be?
You know what? I take that back. I guess not.
Well, I actually could agree with you. I mean, you could think that scar tissue and that kind of stuff could increase your postoperative pain if you're doing more lights of adhesions and that sort of stuff. So, I mean, and it's possible. I mean, it didn't bear out in their study. But again, this is 125 women. It's not a gigantic
sample
study.
Size.
Right. And it's all at one location and all that stuff. So it's, that could be a factor. More than likely, it's not a huge factor. Otherwise, they would have probably seen it. But
right. I guess it depends on what kind of abdominal surgery you've had as well.
Right. Before the show, we were talking about a shared patient who's had so many surgeries that basically, the best surgeons that we know have said no one should ever enter this woman's abdomen ever again. And so she probably would have more pain.
Oh, yes.
Right. Having one or two C-sections, maybe that's not what it is.
Right.
All right. So then they made a calculator based on this. And in that calculator, these are the questions they put in. Do you have a history of chronic pelvic pain? Do you have a history of endometriosis? Do you currently use any opioid pain medications regularly? On an average day, how much pain do you experience? 0 to 10. How much pain do you expect to experience after your surgery? 0 to 10. What do you expect your pain medication requirements will be after surgery? 0 to 10. Over the past 2 weeks, how often have you been bothered by little interest or pleasure in doing things? So that's the depression screen, and that went from 0 to 6. Over the past 2 weeks, how often have you been bothered by worrying too much about different things? As for anxiety, I'm assuming that's 0 to 6. And then to what degree do you have these thoughts and feelings when you're experiencing pain? And like I say, when I'm in pain, it's awful and I feel that it overwhelms me, and that's from 0 to 8. Now, I think that they are pulling these questions out of the questionnaires that they use for anxiety and depression. So the wording they did not create themselves. So that was their calculator. And then what they found using that is that if you had a score of greater than 33, I should say the yes, no's were all 0 points or 10 points. And then all the numerical ones you get, if you said 9 out of 10, then that was worth 9 points. If you had a greater than 33, then you were more likely to use greater than 15 tabs with a positive predictive value of 83.3% and a negative predictive value of 96%. So that was pretty good. And if you had a score less than 12, you were more likely to use 5 or less, with a positive predictive of 83.7 and a negative of 35.4, which isn't so great there. And the positive is still pretty good. Mm-hmm. So, but for most patients there, they were able to, kind of correctly sort them into the right category using this tool.
Aptly named Pooch.
And what did Pooch stand for?
Post-operative opioid calculator for hysterectomy.
All right, I don't really know that they needed to give it an acronym.
It's catchy.
And I guess so. Pooch. Anyway, it's like whenever NASA gives something an acronym, it usually doesn't really work very well for me. But
I feel like all the the big studies in medicine always always have to come up with an acronym, a catchy acronym.
It's all about branding.
Mm-hmm.
And so. Anyway, so the conclusion, and then we can talk about that calculator a little more, is that the average person was given 4 times more opioids than they actually used. That the downsides to giving less prescriptions is decreased satisfaction, potentially, and need for more refills. And that was, they have more comment, but that was basically the meat of their comment. And then, as you said, they're planning on taking this calculator and now doing a prospective study with it to see if it holds up in predicting people's opioid use. Because this was all in this population, so they want to validate it, which is good. I really like their calculator.
Yeah, it's very easy to use. It's short. Definitely, these questions make sense, what they included.
Right. So for a couple reasons, I think that I actually might push to adopt this in our practice, even before it's validated, for a couple reasons. One is that, at least their positive predictive value and negative predictive value for the greater than 33 could help us at least identify the people who probably need more pain meds. Right, and if we say, okay, we're going to give everyone 15, or that's going to be our baseline, that's fine. But if you have someone greater than 33, then maybe we don't need to give them more, but maybe we should see them in a week in the office as opposed to 2 weeks.
Right.
Right. So they're not calling for refills, but we're going to see them an opportunity to give them more if they need it.
That sounds like a good idea.
And then the other thing is, after a year or 2 years of doing our surgeries at Stony Brook, if we're all using this, we can go back and look at this data ourselves. And all that data is there for us to pull out. And so there's a couple of different reasons that might be beneficial. And the other reason that I think it may be worth doing it before it's validated is that there isn't a whole lot of downside to it. Mm-mm. Like, you're not really going to harm people by using this tool. That's not validated yet, because the worst that happens is you have to give them a refill on their opioids.
Right. I feel like for most of us, when we're seeing patients pre-surgically, maybe not all, but some of these questions are running through our heads. But I think what this study has definitely prompted in me is that I should definitely be more, what's the word? Not specific. Tailoring. I should be more tailored in terms of how much I prescribe for patients for post-op opioids.
Yeah, I think this at least prompts you to think about depression and anxiety in every patient, right? It prompts you to think about their preoperative opioid use. Too many times, maybe this is more me, because you're a regular surgeon, meaning that you operate almost every week, right? Whereas I operate like once a month, right? So I'm not doing this on a regular basis. But, sometimes, you see the patient in the office, and then by the time you see them in the, maybe it could be a month later by the time you actually operate on them, like, you don't remember all these details about this particular patient, right? Does she have, depression, anxiety, all this stuff? Unless there's a diagnosis that's written there. But like we said, a lot of these patients don't actually have a diagnosis. Mm-hmm. This is another way of saying you pull this score up when you go to do surgery. Oh, she has a score of a 40, right? Okay, or even if it's a 25, she has a score here. Okay, let's think about that as we prescribe her postoperative pain, and it almost perfectly dovetails into the ERAS thing that you're talking about, because ERAS is a lot about. It's a lot about prescriptive, giving everyone the same bundle to prevent pain, but also part of it is also tailoring their pain regimen to each individual person, unless I'm wrong, right?
No, it is, yeah.
This goes into that.
Yeah, so a part of the ERAS bundle is also for patients with chronic pain and who are using chronic opioids. There are additional medications that are non-opioid to help with managing their pain as well.
So, I don't know. I think we should bring this to our group of surgeons and see if it's something that they're interested in incorporating into our practice.
Yeah, I mean, I think this would be very, very useful. I mean, from our, as a fellow, from our QI study, we definitely realized that we were overprescribing. Some people were prescribing 30, 40 tablets of narcotics for patients after laparoscopic hysterectomy. So from our QI study alone, we have that to 20. And I think personally, I could definitely decrease it by even more than that.
All right. So, I mean, I think it was a very well-written paper. I think they accomplished their goals. They were narrow enough in scope, and that's what I'm looking for. Maybe humble is the wrong word, but humble enough in what they were trying to do that they accomplished it very well. They weren't trying to get too much accomplished in one paper. So I really enjoyed this paper. I enjoyed reading it. The tables are very nice. The graphs are very great. It's one of the few papers I don't have a whole lot of criticisms to lay at it.
I mean, everything was concise. That I think the subject was very practical, and I especially liked that they included the Pooch calculator. I think that's definitely can be very useful in outpatient practice. And this definitely made this paper different from other papers that looked at opioid use after surgery.
I don't think I want to call it the Pooch calculator, though.
I actually like it. I think it's catchy.
All right, we'll have to talk about that offline. All right. I mean, any final comments or any ways you think that besides maybe incorporating the Help Me Pooch calculator into our practice, any other things you take away from it that are applicable to your practice?
One thing that this paper sort of highlighted for me is that talking to your patients about what to do with the leftover medication. That's something I don't do. And maybe that's something I should address because majority of my patients have leftover oxycodones or Percocets, and I think a lot of them do keep it, in their house unlocked. And I am guilty of that too. After I had molar surgery as a resident, and I remember being prescribed Vicodin, and I just recently threw out the pill bottle. So I think that's something that we should be addressing with our patients as well.
No, fair enough. And I think that one of the things that we may want to do as an institution, certainly, but maybe also as a society, is standardize what that education is. And it exists out there. It's not like we have to make it de novo. And then, it could be part of our patient handout stuff that we're giving as part of your surgery. One of the things is, hey, if you have leftover stuff, this is what you do with it. Not that we shouldn't also talk to them,
right? But
giving them some written material to go home with as well. And they're going through their post-op papers at some point, and they're like, oh, right, I should probably get rid of those. How do I do that?
Right.
So I think maybe as an institution, we want to maybe in part as the ERAS, because I know the ERAS has incorporated anesthesia and those other people into a group. It might be a good forum to talk about this and try to come up with some guidelines for us.
Yeah, that would be a good idea.
All right. Well, I think this, it was a good paper. I really enjoyed talking about it. Dr. Lian, thank you so much for being here and spending your night discussing this with me.
My pleasure.
And for everyone else, I think next week, if I can get my act together, will be the first episode of Diabetes and Pregnancy, which has been long gestating, and I'm really excited to get it out of my head and into your ears. So I hope you'll hear that next week. And until then, thanks for listening.